Good evening, sir.
Yeah, hi, good evening.
Sir, will you be telling about HLA B27 also?
Actually, B27 is nothing. I just showed you during our analysis, during the class of analysis. If you want, I can just show you a case, but it's nothing. Like, you just need to gate the lymphocytes and see whether
It is
those
positive or
lymphocytes, exactly, it is positive or negative.
okay.
It should be. So I just showed you a case in analysis. Possibly I didn't show you a live analysis because there's nothing to show in live as a live analysis. Basically, what you need to do is just gate your lymphocytes and check whether it is positive for HLA-B27 or negative for HLA-B27. As simple as.
Okay. Okay, thank you, sir.
Thank you. So, any other doubts? We have a minute, so we'll just discuss something and then we can go ahead. We'll just wait for a minute and then we can go ahead. So today we'll be discussing on lymphocyte subset analysis, and I'll show you some live analysis of basic lymphocyte subset analysis and some extended lymphocyte subset analysis. I'll tell you what is the difference between a basic lymphocyte subset analysis and an extended one during the course of this lecture, and this is the penultimate lecture. So post this lecture we'll have assessment. This assessment will be more of analysis than questions, and then we'll have the last lecture of this particular course, which is on next week, Friday, where I'll be discussing on the reporting guidelines, how to report, how a flow cytometry result has to be reported, and what are the quality guidelines which has to be followed in the flow cytometry lab. That is more like for accreditation and other process, and how does a flow cytometry report look like, and what are all it should bear. So all those things will be discussed next week. So this week, lymphocyte subset analysis. So we'll just start. Yeah. So lymphocyte subset analysis. So the basic purpose of doing this lymphocyte subset analysis is a part of your immune workup. Okay. But immunity is not just about lymphocytes. Okay. It has multiple other cells and other proteins involved in it. Okay. Now, immunity, if you see, it is of two types. One is the innate immunity and the adaptive immunity. You know what is innate or natural immunity, which is already present in the body. Okay. They are already present in the body and they are ready to attack when any pathogen enters into our body. Okay. So the natural or innate immunity is contributed by macrophages, dendritic cells, mast cells, basically your cellular component as well as the complement. Okay. And whereas if you check what is adaptive immunity or acquired immunity, it is the one which you acquire when a pathogen enters into your body. So in a well-being state or in a state when you have just born, say for example, that's the best way to say, a just born baby, okay, may not have a much adaptive immunity, okay, because it is just born and it is not exposed to any pathogen. So once it is exposed to pathogen, the pathogen enters into the body, then the adaptive immunity starts developing. So it is majorly contributed by the T cells and B cells. B cells will take care of your humoral response, that is secretion of antibodies, and the T cells will take care of about cell-mediated immunity. Okay, so that is about the adaptive immunity, and some cells will be taking part in both the natural immunity as well as the adaptive immunity. And let me put one important point, which is very important: T cells or B cells. Let's make it interactive. What do you think is very important, the T cells or the B cells? Just give you a blind guess what's wrong. You can just guess.
So T cells.
Yes. See, the T cells are very important because the T cells are the one which will activate the B cells. In fact, if you have a problem in the T cells and you have a good number of B cells, okay, it is useless because you actually need the T cells for activating the B cells. Okay, so if there is a defect in the T cells, either quantitatively, which means the numbers, or qualitatively, that is functionally deficient, then no matter you have any number of B cells which are competent, it is useless because you need the T cells to activate the B cells. Okay, so the T cells are the very important component of your adaptive immunity. In this class, I just don't want to stick only to lymphocyte subset analysis. Just say like CD19 positive cells are B cells, CD3 positive are T cells. Just get them and see the percentage and give the numbers. So that will not give the entire essence of doing a lymphocyte subset analysis. The components which I'm covering in this particular course, that is a lymphocyte subset analysis, PNH, CD34 enumeration, of course HLA-B27. Though I didn't show you a live case, it's very simple. So these things has to be started. If you have a flow cytometry, you should start these particular assays in your laboratory. Okay, and lymphocyte subset analysis, most people what they do is that they get the sample, even the technician is there, the company people will give you a software or a protocol. What I mean to say a protocol is, we acquire the samples during acquisition, I told you, right? So when you acquire the sample, you need to drag a protocol into which the data will be captured. That is called a protocol, or some people call this as template. Okay, so once you want to acquire a sample, you need to acquire it on a protocol or a template. Okay, so the company people, when you don't have a good flow cytometrist in the laboratory and you want to do CD4 count, what they do, they just create a template of setting up auto gate. Okay, so they'll set a gate and they will lock it. So what happens when you run the sample, whatever events falling in that preset gate will be counted as the population, and the percentage and the absolute counts will be given. Okay, this is okay, but you should have a knowledge of, is it doing it rightly? Like at least you should report it with supervision. I have seen many labs where they report just the values which is being given. They don't even look at the plots. Is any debris have been included? Is the gates are correctly done? They don't even check that. Whatever values it is displaying in the statistics box, they just give the values in the report. That should not be the case. I strongly condemn that. You should have an idea of what is being happened. Are the gates correct? Because when as we saw, when the voltages or any other changes happen, these gates which have been already set becomes waste. Okay, and the population may fall outside. Since the gate has been set, it may show just 2 cells, whereas it may be a big bulk of cells which is lying outside the gate. Okay, maybe with a lesser intensity or a more intensity. Then the gate, the value which you are giving is absolutely wrong. So you should have an idea. It's fine to have auto gates and directly get it from the template, but still I would suggest everyone has to supervise that is the gates are all correctly drawn, are the regions correctly drawn, and the populations are all fine. There is no debris or any other artifacts which is involving in the false counts. All these things has to be checked. Okay, and that is the reason why I want to take why this test is being done, lymphocyte subset analysis, why it is being done. Just telling lymphocyte subset analysis doesn't make any use. Okay, so this is about the innate immunity and the adaptive immunity. And then, as you know, the immunodeficiency, which is lack of immunity in a very simple sense, is of 2 types. One is primary and the secondary. So you know what is secondary? Secondary is like you are immunocompetent, but because of certain infections or drugs or some diseases or because of malnutrition, you are becoming immunodeficient. Okay, so that is secondary causes why immunodeficiency. Okay, whereas primary is something like what you inherit. Okay, because of a gene mutation. Okay, so from the newborn period, you have this particular gene mutation, and you are immunodeficient since the birth. Okay, so that particular immunodeficiency type is called primary immunodeficiency, which is inherited and because of a genetic mutation. Okay, now this is called as primary immunodeficiency disorders, shortly called as PID. Earlier it was called as primary immunodeficiency disorders or PID. Now a new term has been given to this, which is called inborn errors of immunity. Okay, we have inborn errors of metabolism, right? Similarly, we have these entities have been renamed as inborn errors of immunity. Okay, so this is about primary and secondary immunodeficiency. Now, so basically, when we ask someone like, what happens when your immune system goes down or if you are immunodeficient, everyone says there is infections. It's not just infections, mind you, because the immune cells are not only just fighting against the pathogens, it also fight against the tumor. So it has an anti-tumor activity going on. So when your immune system goes down, then there's a chance like malignancy crop up. Okay, so it could be just like a malignant cell which has to be controlled. Okay, if the immune system is very weak, then these malignant cells or a mutation which has happened these cells will not be killed and they proliferate and form a tumor. Okay, similarly EBV or some infections may come which can give rise to lymphoma and other malignancies or viral infections induced malignancies. So even these has to be checked by the immune system. So it's not just defense against microbes, and it's also for tumor surveillance. Okay, especially the cytotoxic T cells has an anti-cancer effect because of MHC class 1 molecules. Okay, apart from that anti-tumor effect, they also have an immune tolerance. Okay, what I mean by immune tolerance is, do anyone know what is T regulatory cells? Do anyone know what is T regulatory cells? You can just give a blind guess, no problem. T regulatory cells. Any idea? Okay. Now, T regulatory cells are a subset of T helper cells, which is CD4 positive T cells. These T regulatory cells, the basic function of these T regulatory cells is to maintain a harmony between the immune system and the host. Okay. When these T regulatory cells go down, then there is a chance of autoimmunity. That is, your own immune system will attack our own tissues and cells. Okay, so this T regulatory cells plays a very important role in maintaining the harmony between the immune system and the host. Okay, so that is called immune tolerance. Okay, so when this particular immune system goes down, then there is a immune dysregulation, or which is called as autoimmunity or something. Okay, so that if you want me to name the inborn errors of immunity which occurs due to lack of T regulatory cells is called IPEX syndrome. IPEX syndrome. Okay, so it's not just immune system is only looking into pathogens and antimicrobial activity. No, it's not like that. It has a surveillance on the tumor and other things, and also on immune tolerance. Now, just a quick review of what is PID or inborn errors of immunity. So these are group of inherited disorders that can affect cells of the innate or adaptive immune system. Okay, so don't think it will just inborn errors of immunity will only be involving the T cells and the B cells. It can involve the innate immunity as well. Okay, it could be a complement deficiency, it could be a neutrophil problem or a phagocytic defect, or it could be a B cell defect or a T cell defect. Okay, so they are not uncommon, but the problem is they are not being efficiently diagnosed. Now it is good we are diagnosing because the awareness has come, but most of the PIDs go undiagnosed. Okay, so it is not uncommon, but it is not rare. You can still have a lot of PID cases if you do a good diagnostic workup. Overall prevalence is around 1 in 1200, and it can present at any age. Okay, any age from the newborn period to the adult. Okay, and this also depends upon the PID. Depends on the type of PID and the age of presentation. Okay, so if you have a T cell defect, okay, it presents more in a younger age group or in a early age group. For infant, it can present in less than 2 years or 3 years. Okay, but on the other hand, if you have an antibody defect, which is humoral immunity defect, it can present more in the later age group. Okay, so it also depends upon the type of immunodeficiency, and the age of manifestation depends upon the type of immunodeficiency the patient has. And recognizing different clinical manifestation of PID is a very important step. Okay, different clinical manifestations. For example, one dictum for diagnosing inborn errors of immunity is that if you find a uncommon infection in an uncommon site, okay, so then you need to suspect PID. Okay, and recurrent infections. Okay, I'll just show you that. So these are the 10 warning signs when you need to suspect a primary immunodeficiency, and this has been led by Jeffrey Mondale Foundation. Like See, 4 or more ear infections within a year. So this is if the patient is having such a problem, say like repeated ear infections, then you need to suspect that there is some problem with the immunity. Okay, 2 or more serious sinus infections within a year. Okay, 2 or more months on antibiotics with little effect. 2 or more pneumonias within 1 year. Failure of an infant to gain weight or grow normally. Okay, recurrent deep skin or organ abscesses. Persistent thrush in the mouth or fungal infection of the skin. Okay, need for intravenous antibiotics to clear infection. So they may not respond to oral antibiotics. You need this intravenous antibiotics. 2 or more deep-seated infections, including septicemia. And very, very important is a family history of primary immunodeficiency. Okay, so these are the 10 warning signs. And if there are these signs in a particular patient, then you need to strongly suspect immunodeficiency. Okay, so these are the classifications of inborn errors of immunity or PIDs, which include combined immunodeficiencies with syndromic features, antibody deficiencies, immune dysregulation, which I told you, like disorders of autoimmunity, congenital defects of phagocytes, defects in intrinsic and innate immunity, autoinflammatory diseases, complement deficiencies, bone marrow failure, and phenocopies of inborn errors of immunity. Okay, so these are the broad headings of classification of inborn errors of immunity. Okay, but if you see the number of PIDs or individual PID diseases as such, it almost reached 500, and still the numbers are increasing because of sequencing and molecular advancements. Every time a patient is diagnosed with immunodeficiency, they send for a gene sequencing, exome sequencing, and they pick up a new mutation, and it adds up to the list. Okay, so the number of PIDs are steadily increasing in number because of this genetic advancement in genetic studies and sequencing, next generation sequencing. Okay, now this is a beautiful diagram. Do you know where I took this from? Anyone?
Robbins.
Yeah, Robbins. It's a very, very. I'll still tell you the best book for pathology, which you need to give a quick pressure. Say, for example, in a shorter period of time, you take Robbins. Beautiful book. See, during my undergraduation, possibly I read this without not understanding this. Even during my PG, I have not given much importance to this. Okay, but this is a beautiful diagram. Okay, which shows hematopoiesis. Okay, especially the lymphopoiesis, and they have beautifully shown where the mutation happens and what is the problem that will arise, or what is the PID that comes. For example, now this is a pluripotent stem cell, and you have the common lymphoid progenitor. The common lymphoid progenitor differentiates into B or T. When you have a mutation here or here, you have ADA deficiency because of an ADA deficiency. Then the patient presents with both B lymphocyte deficiency and T lymphocyte deficiency, where we call it as T minus B minus combined immunodeficiency. Okay, I'll just discuss that later, but still. And if you have a problem in this area where there is no mutation in the differentiation between differentiation into B or T, but you have a mutation in this area, now what happens? The T cell maturation and functioning will be absolutely normal, but the B cell differentiation from pre-B cell to immature B cell, there is a problem because of this mutation. This is called X-linked A-gamma globinemia. So these patients have normal T cells, but no B cells. Okay, I'll show you some cases, but this is okay. Similarly, you have the T cells where the mutation is not happening here in the early stage, but after it has been committed to T cells. Okay, now if this mutation happens here, then you get X-linked SCID. That is, it is T minus but B positive. That is, B is present. Okay, so T negative, B positive SCID. Okay, SCID means severe combined immunodeficiency, which I will discuss. Okay, so similarly, when there is a mutation here, then you get DJOT syndrome. Similarly, you have a mutation in this particular differentiation pathway, you have MNC class 2 deficiency. Okay, so this is a very beautiful image. Okay, and similarly, when there is a problem in class switching, anyone knows what is class switching in B cells?
They are destined to single class antibodies, production of antibodies.
Class switching defect. What is class switching? What is normal class switching? Where it happens? No problem. You are half right. Like, you can just complete it. See, class switching is something like when a B cell is produced, it is called naive B cells. Similarly, when a T cell is produced from its immature stages, it is called naive T cell. Okay, or you can also say that it has not encountered a pathogen yet. Okay, so such a naive B cell, when it encounters a pathogen, it differentiates. Okay, a part of it, what it does, it goes into secondary lymphoid organs like lymph node, and there it goes inside the germinal center. Then it undergoes a process called class switching, because the naive B cells, which is formed from the immature, for example, hematogones, they basically show only IgD and IgM immunoglobulins on its surface. Okay, so as I shown here, IgD and IgM immunoglobulin on the surface. But once it goes to the germinal center, it undergoes class switching. That means now these two will go down regulated, and it exposes the other immunoglobulins like IgA, IgG, and IgE. Okay, this is called class switching. Okay, now that is why the reason is, if you get a viral infection, which antibodies go high first? IgM.
IgM.
Right? Yeah, so IgM. Once class switching happens, what happens? IgM comes down and then IgG goes up. That is the reason. You understood? So immunology is a beautiful topic. You know, if you love it, it's like mathematics. You understand a lot of things. Okay, now if there is a problem in the class switching, as I told you, that is called CVID, combined variable immunodeficiency. Okay, so once what happened is that when I was doing histopathology, initial days, like after my pathology post graduation, I just called a very good senior pediatrician. I said, like, I just saw an intestinal biopsy and there were giardia. Okay, so I just called him and saying, like, sir, this duodenal biopsy is showing giardia, because I was excited. Okay, giardia. When I was in the phone call, he just asked me, like, are you seeing plasma cells? He asked me. I didn't expect that question from him. Why should he see? I'm telling him a great finding. To me, finding a giardia is something I was very thrilled. I'm telling you, I thought like he would appreciate me. He asked me, like, do you see plasma cells? I didn't understand why he's asking for what bothers him to see a plasma cell there. Then I just saw the slide again and there were no plasma cells. It's predominantly lymphocytes. I said, like, sir, I couldn't find any plasma cells. Then there could be CVID. So that is the expertise what he had at that time. And then I understood, like, why he asked for plasma cells. Because there's a class switching defect, and only when the B cells go for class switching, they go for plasma cells, which is the terminally differentiated stage of B cells. Okay, so when there is a CVID, then the class switching does not happen and you don't get plasma cells. Okay, there are multiple types of CVID, but it's a differentiation if the class switching is a problem. Okay, so that is the reason why he asked. So when a patient is having a CVID, he has an humoral deficiency. Humoral deficiency means antibody deficiency, and these patients are prone for giardiasis. So that is how you should see pathology. And whenever you find cytomegalovirus in a children, okay, in a children who's not under chemotherapy or any other immunodeficiency state, then you need to suspect that it could be a case of PID. Okay, and that's how we need to work, right? So this is a beautiful image, and these are the different very common PIDs which I've shown you. There are multiple. As I said you, there is around 500 PIDs, but these are the commonest types which has been shown in our Robbins. Okay, now how does flow cytometry help in the diagnosis of inborn errors of immunity? Okay, now before going into flow cytometry, before you see the flow cytometry, you need a good history and clinical findings. Okay, for example, if the patient has a complaint or the clinician has noticed that there is no tonsil in the patient, okay, the patient is not having tonsil, then I suspect strongly that could be a case of agammaglobulinemia. Okay, so these are very, very important findings. When the patient is having elevated B12 levels and lymphocytosis, then that could be autoimmune lymphoproliferative syndrome. Okay, that could be double negative T cells. So these findings are very important, and a very strong family history, say like a early sibling died and this child is having repeated infections. See, there is definitely something with this child. Even if your flow is not helping, you need to progress, you need to do molecular. Okay, so that good history and clinical finding is very important, and you should always correlate with immunoglobulin profile. For the simple reason, like when you find any abnormality in flow cytometry, especially in the T or B, the immunoglobulin is something, it's like a functioning evidence. If immunoglobulins are low, that means there is some problem. There is some problem. Okay, for example, if the immunoglobulins are normal and if your T cells and B cells are all looking fine in flow cytometry, then it means like it is more or less not related to a combined immunodeficiency or a humoral deficiency, antibody deficiency. It is dealing with something else. Okay, so you always need to correlate your flow cytometry results with immunoglobulin profile. Okay, should be interpreted with age-matched control reference age. You can't check, for example, you are doing lymphocyte subset analysis for a 10-year-old boy and you have got an absolute count of say 600. You can't compare that with a newborn. The newborn period, the absolute counts may be high. Okay, and comparing that, you cannot deem this child to be immunodeficient. Then you're wrong. You need to always interpret your report with the age-matched control. Age-matched, it should be an age-matched control. Okay, so you should keep that ready and you should also put that in your report when you're doing lymphocyte subset analysis. Okay, and then a normal control sample should be processed for some test. Not all tests, for some tests, especially activation assays and so also. A normal control sample should be processed in parallel along with the patient sample, just to check everything is right. For example, a DHR assay or something like that. To check whether the processing part is right, you need to put a control sample parallel with the patient sample. So if the control sample, we know that it should exhibit normal function. Okay, if the control sample is showing normal function, then your processing is right. If the control sample is showing abnormal findings, then it means like your processing is wrong. You need to repeat it. So that is the reason I say, because a normal control sample should be processed in parallel along with patient sample. This is done mostly in activation assays or functional assays. Okay, so that you need to understand. Now, I'll tell you what is functional assay and so on. Now, the diagnosis of inborn errors of immunity by flow cytometry is of 3 different types. So almost the diagnosis of PIDs by flow falls into these 3 categories. One is decrease or absence of one or more immune subsets. For example, as I said you, a patient is having no T cells. Okay, or if a patient is having no T cells, no B cells. Or if a patient is having no T cells, B cells, NK cells. Something like to do with quantitative defects, numbers, with the numbers. The patient is having no neutrophils, congenital neutropenia. Okay, so decrease or absence of one or more immune cell subset. A good example is severe combined immunodeficiency. Okay, so second is absence or decreased expression of specific proteins. Okay, for example, there is something called BTK. Okay, gluten tyrosine kinase. So this is normally expressed in B lymphocytes. Okay, in cases of XLA where there is no B cells, you find this BTK to be not expressed. Since there is no B cells, you need to check that in monocytes. Okay, so this BTK will not be expressed in monocytes. Similarly, Viscott-Aldrich syndrome. If you want to diagnose Viscott-Aldrich, there is a protein called VASP protein. Now, in cases of Viscott-Aldrich, there is a mutation in this mutation which results in no VASP protein. Okay, and you can see that the expression of VASP protein will not be there in the cells, the lymphocytes, or basically the lymphocytes. Okay, so that's how you diagnose VASP. Similarly, MHC class 2 deficiency where HLA-DR is not expressed in B cells. So we diagnose some PIDs by checking the expression of certain proteins. Okay, and third is the one which I told you. These are all functional assays where you stimulate the immune cells to check whether it's doing its function. So here what you do, you activate the immune cells in vitro by a stimulant. Okay, and check whether it is doing its function. For example, if you want to, if the neutrophil numbers are low, it is congenital neutropenia or neutropenia, cyclical neutropenia, whatever type. If the neutrophil numbers are good, but still the patient is having a lot of abscess and so on, so problem recurring repeated abscess and so on, so then these neutrophils are there. By quantity wise, it's fine, but quality wise, it's defective. Now, how do you check that? One test is chronic granulomatous disease. How do you check this? By activating the neutrophils with a stimulant and checking whether they are doing an oxidative burst. Because this oxidative burst is very important to generate superoxide, which will kill the bacteria. Okay, so this assay is called DHR assay, which is used in the diagnosis of chronic granulomatous disease. Okay, now these are the flow cytometry test, and these are the diagnoses which can be made by flow cytometry. Okay, I have not included completely. There are many other activation assays, but these are some of the assays which we can do in our laboratory. I am doing this assay, which I will show you today. Okay, so basically a simple lymphocyte subset analysis where we study the lymphocytes and segregate them into T lymphocytes, B lymphocytes, NK cells, and T lymphocytes still into CD4 positive T cells and CD8 positive T cells. So doing that is called lymphocyte subset analysis. Now, what is extended T cell phenotyping is, so apart from just checking the T lymphocytes as CD4 and CD8, in every compartment, I'm going to check how many are naive cells, how many are central memory cells, how many are effector memory cells, and how many are terminally differentiated cells. So checking that is called extended T cell phenotyping. And similarly, extended B cell phenotyping is, apart from getting the B cells and studying the numbers, I check whether the B cells are showing class switching, which I just explained. Are they showing class switching? If there is no class switching, then there is a problem. It could be CVID or hyper IgM syndrome. Okay, so, and similarly, you can also check HLA-DR expression, which will be absent in MNC class 2 deficiency. So this is something about lymphocytes subset analysis or an extended T or B cell phenotyping. And there is something with flow cytometry which you can diagnose, which is CGD, as I just said you. You can also diagnose HLH, okay, and you can also diagnose LAD, where the neutrophils will not show integrins. You know what is integrins, right? Again, Robbins. If you go to the chapter of immunity, the neutrophils will start rolling, adhesion, margination, so and so, right, to go to the site of inflammation. Okay, so even that, if when that integrin is absent on the neutrophils, that particular disease is called LAD, leukocyte adhesion defect. Okay. Similarly, there are many other assays, like as I told you, double negative T cells, which is used in diagnosing of autoimmune lymphoproliferative syndrome. So there are many other assays, but so these are some of the assays which I want to discuss. But today I'll be restricting to lymphocyte subset analysis, and I'll just show you a glimpse of extended phenotyping. Okay. Now, the other advantage of flow cytometry is, like, for diagnosis of inborn errors of immunity, you basically need to do flow cytometry and genetic molecular studies. So not all inborn errors of immunity can be diagnosed only by flow cytometry. Okay. So you need to do invariably molecular studies or exome sequencing to find what is a genetic defect in that particular child. And once you get a genetic defect, to validate it, you need to do flow cytometry. Because you know what the problem with next generation sequencing is, that it can give you a lot of VUS, that is variant of unknown significance. Okay, which you don't know whether to take it as pathogenic or not. Okay, if it is giving it as pathogenic also, I have seen a case where congenital neutropenia was given by next generation sequencing. Okay, and it was said likely pathogenic. But when I saw the marrow, the neutrophil maturation is beautiful. And there are neutrophils in the smear also, peripheral blood also. So whatever genetic studies has given, you cannot take just like that. You need to check with the phenotypic expression. And flow is a very beautiful platform to check whether the phenotype is correlating to genotype or it is not correlating. If it is correlating, you can take the diagnosis which has come from sequencing. If it is not correlating, then still you can't take it. Flow cytometry, it's simple and rapid assay. See, if you are sending for next generation sequencing, for you to get the report, it definitely takes a week or beyond that. Okay, flow cytometry, if you give the sample to today morning, I can give you the report by today evening. Okay, and prenatal diagnosis. So flow is also used in prenatal diagnosis. So we receive samples of umbilical cord. Okay, where the parents had an earlier child with a SCID or CGD or something. So this umbilical cord sample comes, and you can check whether the current baby immune cells are functioning fairly normal. So that also can be done. And post-transplant monitoring. So, for example, there is a case of chronic granulomatous disease where the neutrophil function is abnormal. They have transplanted that child. Okay, bone marrow transplant has been done for the child. Now it is engrafted and new neutrophils are coming out. You can check whether those neutrophils are normal. So if it is normal, then means the stem cells are engrafted and new neutrophils are coming out of the marrow. If still those neutrophils which are in circulation are defective and they are not showing oxidative burst by DHR assay, then it means the stem cells have not got engrafted and the neutrophils of the recipient himself is coming out. Okay, so post-transplant monitoring, so it can act as a chimerism check also. Okay, so any doubts till now? Any doubts? Am I clear? If you have any doubts, you can ask me. Now I'll go for lymphocyte subset analysis. So this 20 minutes or 25 minutes, we just add an idea about what is inborn errors of immunity or PID. No doubts? Perfect. Now lymphocyte subset analysis. So why lymphocyte subset analysis? Basically, as I told, to diagnose inborn errors of immunity. But most of the workload for CD4 count comes because of retroviral infection. Okay. Similarly, when the patient is put on immune suppression, for example, if the patient is having autoimmune disorders or something, and he wants to put on immune suppression, then you want to check whether how the immune cells are suppressed. Is your drugs working or not? So you can check lymphocyte subset analysis in that setting. And fourth, if, for example, a patient has been put on rituximab, you know what is rituximab, right? Rituximab is anti-CD20 molecule monoclonal antibody therapy, basically to limit the B cells. Okay, so to kill the B cells, because these patients have problem because of B cells, so they put the patient on rituximab so that the rituximab will eliminate all the B cells, and in such a way the immunoglobulins are not secreted. So to check whether the rituximab functioning is good and whether the CD20 cells are not there or the B cells are present or not post rituximab or before rituximab. So in that setting, a lot of samples will come in for lymphocyte subset analysis or B cell count, and to assess immune reconstitution post BMT. So you have done a bone marrow transplant and then you want to check whether the graft is the graft which you have given from the donor has engrafted into the recipient and it's producing normal immune cells. So in that setting, you can also check the lymphocyte subset analysis for immune reconstitution. So these are some of the indications. And as I told you, what is basic lymphocyte subset analysis is you classify the lymphocytes or you quantify and tell the numbers, absolute numbers of T cells. Okay, in T cells, you need to say the total T cells, the CD4 positive T cells, which is called the T helper cells, the CD8 positive T cells, which is the cytotoxic T cells, then B cells and NK cells. Okay, and you know how to do that, because the T cells will have CD3 positivity, CD2 we rarely use, but still CD3 and CD2 positivity. T helper cells is CD3 positive and 4 positive. Cytotoxic is 3 positive and 8 positive. T cells are 19 positive or 20 positive and 20 positive. NK cells are 3 negative and 56 positive. So this is the phenotype of these subsets, and you give a report of all these subsets with percentage as well as the absolute counts in the peripheral blood. So that is the basic idea of lymphocyte subset analysis, what we do in our laboratory by flow cytometry. Now this is how we do this. So first what we do, we gate the lymphocytes. You know how to gate the lymphocytes, right? So site scatter CD45, the population which is bright CD45 is gated, and that particular gated population is applied here. Okay, so once it is applied, you gate the 19 positive cells, which are the B cells, and then you gate the CD3 positive cells, which are the T cells. Okay, so now, as I said earlier to you, whenever it comes to an enumeration assays, what all you need to take care when it comes to enumeration assays, what type of processing you do, someone has to say me. For enumeration,
Stain, lies, no wash.
Perfect.
Lies, no wash.
Perfect. Stain, lies, no wash. No wash. Okay, so whenever you are doing an enumeration assays with beads, you should not wash it. Okay, to make it very clear, when you are doing it by single platform method, that is, you are using the flow cytometer to give your absolute counts without touching your automated cell counter. Okay, which is called the single platform method. You will be using something called beads, calibration beads. So when you are using the calibration beads, you should not wash the sample, because washing will lead to cell loss. Okay, so you should not use washing. You should not do washing. So this is a single platform method. So I've added beads and I've programmed in the software that the absolute counts are automatically given to me. Okay, now once I get the CD45 bright lymphocyte population, I get that particular population in CD19 versus CD3 plot. So I get 3 populations. One is the CD19 positive population, which are the B cells, and the CD3 positive population, which are the T cells, and a double negative population. Okay, now once if I have the software, I'll get the values. Like now the B cells are 846 cells per microliter, and T cells are 2230 cells per microliter. Now what I do, I gate this cells which are negative for 19 and 3 across CD4 and CD16 plus 56, which is the NK cell marker. Now the cells which are positive for 16 and 56 will be taken as NK cells, and the absolute count of that will also be given automatically by the software. Okay, or you can also manually calculate by the number of events, and from the number of events in this particular population and the number of events in the beats you got, and you can also manually calculate. So this is 696, and then the T lymphocytes are gated across 4 and 8, and you check how much is CD4 positive and how much is CD8 positive, both the percentage as well as the numbers. Okay, so you get that. So giving this report is called a basic lymphocyte subset analysis report. Okay. Now see, this is a condition where you find this is normal. This is normal. This is how a normal lymphocyte subset analysis looks like, where you find cells in every compartment in good numbers or the normal numbers. Okay. Whereas you see this particular patient where the B cells are present, you find there is no T cells. You find there is no T cells. And the cells which are negative for 19 and 3 cells which are negative for 19 and 3, when I get it in NK cell marker 16 and 20, I see some NK cells are there. But there are no T cells. So whenever you are finding reduced number of T cells, okay, then you will be giving a term called combined immunodeficiency. Why is that? Now, in this case, I am finding B cells. T cells are not there, but still I am using the word combined immunodeficiency. I should rather use T cell deficiency, right? Why I am using combined immunodeficiency? Anyone?
Or is that defect in that ADA pathway that we showed?
Sorry, ADA. If there is a problem with the ADA deficiency, that B cells will also not be there. ADA is a very important molecule for this purine metabolism, right? Yeah, vague memory, purine metabolism. So if ADA deficiency is there, then you will not have both the lymphocytes, B lymphocytes as well as T lymphocytes. My question is, in this case, I am finding B cells of normal numbers. Okay, 921 cells per microliter. And I'm not finding only the T cells, but still, why should I call this as combined? I can call it as T cell. If it is like B and T both are absent, then I can use the term combined immunodeficiency. But now only T is absent, then why I'm using the word combined immunodeficiency?
No, you said something about the T regulatory cells, which will help the B cells.
Before that, I said something that you forgot. For the functioning of B cells, you need T cells.
Require the T cells, yes.
Yeah.
Because
so
T will also not one.
Exactly. So nevertheless, you have good number of T cells. If you don't have, nevertheless, like you have good number of B cells. If you don't have T cells, then the B cells are useless. Okay, that is the reason why whenever you don't find any T cells, though your B cells are there or your NK cells are there, still you call the word combined immunodeficiency. Okay, so combined immunodeficiency is characterized by defect in T lymphocyte and B lymphocyte function. I have not said the numbers. Function. That lymphocyte function may be because of number or because of absence of T cells for activating them. Okay, so that is the thing. As T cells are required for activation of B cells, quantitative and qualitative T cells defect can affect the B cell function. Okay, now these are some of the type of combined immunodeficiencies. Okay, now this is normal, where you find once I get the lymphocytes, you can see that this particular population falls. The lymphocytes splits into B lymphocytes, which is CD19 positive, and a part of lymphocytes are CD3 positive, which is T lymphocytes, and the population which is double negative is showing 56. So you have all the three elements, B, T, and NK. Now this is a case of T negative, B positive, NK negative SCID. Okay, SCID means severe combined immunodeficiency. When the lymphocyte count is less than 300, we call the name severe combined immunodeficiency. Okay, you find there is no CD3 positive cells at all, whereas you find the B cells are there. NK cells are also reduced. Okay, so it is T negative, B positive, NK negative SCID. Okay, whenever there is no T cells, KIT will come. And if it is less than 300, severe combined immunodeficiency will come. Okay, when if it is so severe means very, very severe. When like the count is very low. But whenever there is no T cells, you should use the word combined immunodeficiency. Okay. Now this is another case where you find B cells to be normal, NK cells to be normal, but T cells are not there. So T negative or T minus, B positive or B plus, and NK plus or NK positive skin. Okay. Similarly, in this case, you find there is no T cells, no B cells, but NK cells are there. So it is T negative, B negative, NK positive skin. And in this case, you find there is nothing. Even in the gate, there is no lymphocytes at all. So there is no T, no B, no NK. This is how ADA deficiency presents. Okay. Now, this is what I told you. So ADA typically presents with T negative, B negative, NK negative skin. Okay. So other gene mutations and the lymphocyte phenotype I have given here. Okay. IL2RG and JAK3 presents with T negative, B positive, NK negative skin. And IL2RG is an X-linked deficiency, X-linked disorder. Similarly, RAG1, RAG2 can give you a T negative, B negative, NK positive skin. And similarly, a T negative, B positive, NK positive skin can be because of interleukin 7 receptor problem or CD3 delta or any other things. Okay.
Sir, in T negative, B negative, NK negative cases, how to select the population?
How to select the population is like you know where the lymphocytes will fall, right? So you have the neutrophils, you will have monocytes, and you find the lymphocyte region vacant. Or see, this is completely absent, but sometimes you will have small cluster. You will not find that dense good cluster as we find. So I don't have a say. So you don't find a very good dense cluster like this, but some events will be there to help you out. Or even if you don't have, still if you see with site scatter CD3, site scatter CD19, you can confirm it.
Okay, sir.
Okay. And now what is A gamma globinemia? You have lymphocytes. Okay. So you know what is this population now? What is this population?
Monocyte.
Yes, monocyte. Okay, so I've just gated the lymphocytes. Now I'm checking with CD3, CD45. So CD3 positive population is there, and it looks fine. Count wise, percentage wise, or the count wise, it looks fine. So CD3 is there. Can I call this as combined immunodeficiency now? Can I use the word combined immunodeficiency here?
No, sir.
No, because T cells are there, right? Now T cells are there, but when I get the same lymphocyte across 19 and 56, 56 positive population is there. That is NK cells are there, but the B cells are completely absent. So when you have a pattern like T positive, B negative, or B0, like it will be very less, B negative and NK positive, that condition is called as A gamma globinemia. Okay, which could be X-linked or autosomal recessive. Okay. Now, most common is X-linked, which comes in males, obviously, and it is because of BTK deficiency, protein tyrosine kinase deficiency. Okay. So this is again a case of X-linked A gamma globinemia. Okay, they will find no B cells at all. You find T cells and NK cells. Okay, and very important. Whenever you are giving this, don't be in a hurry to give it as X-linked A gamma globinemia. You never know, the patient may be on anti-CD20 therapy. So always ask for rituximab, history of rituximab. These all have happened. They give rituximab and they just write lymphocyte subset analysis. So when the technician is seeing it, sir, there is no B cells. So one of the registrar, they called, it could be X-linked A gamma globinemia. Then when we just asked for the history, they have given rituximab. So you should be very careful before putting these terminologies. Okay, check whether there is any drug given. Try to correlate with clinical symptoms. Ask them whether there is repeated pneumonia or any infections. Is there tonsils? Is tonsils absent? Is the lymphoid organs? Like you need to ask for history before giving the final diagnosis, because these diagnoses are something like malignancy. These diagnoses, KIT, X-linked A gamma globinemia, immunodeficiency diagnosis is something like your malignancy, because these patients most of these conditions has to be treated by bone marrow transplant. Okay, so be careful before giving such diagnosis. Now we saw what is lymphocyte subset analysis. Now what is the purpose of doing a extended lymphocyte subset analysis? When simple lymphocyte analysis itself can give you the diagnosis of SCID and XLA, why you need to do a extended lymphocyte subset analysis? I'll tell you what is extended lymphocyte subset analysis. So the basic lymphocyte subset analysis, which includes checking the T cells, the B cells, NK cells, and T helper cells and cytotoxic T cells, and that may not be sufficient to diagnose cases like leaky skin, Oman syndrome, MHC class 2 deficiency, CVID, hyper IgM syndrome, or autoimmune lymphoproliferative syndrome. So these are some inborn errors of immunity which cannot be diagnosed by simple lymphocyte subset analysis, but can be diagnosed when you do an extended lymphocyte subset analysis. Okay, now what is extended lymphocyte subset analysis? So I told you that this is basic lymphocyte subset analysis where T, P, and NK, and among T you can know what is CD4 positive T helper cells, CD8 positive cytotoxic T cells, and of course negative for both is double negative cells. Extended is nothing. Now the helper cells will be divided into naive and memory. Okay, and memory can be still divided into central memory, effector memory, and terminal differentiated. Similarly, for CD8 positive, you can differentiate them into naive cells and memory cells. Naive cells are cells which have not yet encountered a pathogen. Memory cells are those which have encountered a pathogen and they are differentiated into memory cells. Okay, similarly, for B lymphocytes and double negative can be further divided into gamma delta cells and alpha beta cells. These alpha beta cells, when they are increased in number, double negative alpha beta, when it is increased, we call it as autoimmune lymphoproliferative syndrome. B lymphocytes, again, by doing an extended lymphocyte subset analysis, we can find the naive B cells, the class switched B cells, the plasma cells. Okay, so if there is no plasma cells, then and there is no class switching, it's combined variable immunodeficiency. Okay, so that's how we diagnose. Okay, right. So that is about extended lymphocyte subset analysis. Okay, that's the difference between basic lymphocyte subset analysis and extended lymphocyte subset analysis. Any doubts? No doubts? Clear, right? You are following me, right? Right. So you can also check recent thymic emigrants, which means like new T cells which are coming out of the thymus. Okay, in patients of severe combined immunodeficiency, you may have RT George syndrome, you may have decreased RT, recent thymic emigrants. Okay, and this is the phenotype of the subsets what I told you. Okay, basically the same, but we are using RA as a naive marker. Okay, and 27 to check differentiation between memory and other things. Okay, I'm not going to go very detailed into this because this is not something which is taught. You have to learn it by yourself. Okay, now you see here, this is CD4 cells. Now getting the CD4 cells across CD27 and RA tells me about naive cells which are positive for both RA and 27, central memory cells which are negative for RA and positive for 27, and effector memory cells which are negative for both RA and 27. And here it's the terminal differentiated CD4 positive cells falls here. Okay. Similarly for CD8 also, the same markers, RA expressing and 27 expressing is naive CD8 positive T cells. RA negative and 27 positive is central memory. RA negative and 27 negative is effector memory cells.
So what is TEMRA CD4?
TEMRA is terminally differentiated. That means these cells are almost actively fighting cells. So if you take a T cell or a CD4 positive T cell, before encountering a pathogen, it's called naive cells. Once it encounters a pathogen, it gets activated, it proliferates. Once it proliferates, a subset will go as central memory. That means it will not fight with the pathogen. Okay, it remembers the pathogen and stays in the secondary lymphoid organ. Whenever the pathogen comes again, now these cells immediately start functioning rather than the naive cells going and interacting with them. Effector memory is a subset of the proliferated T cells which fight and then differentiate to memory. Okay, TEMRA is something like the cells which are fought, and we can tell also like senescent cells. They're almost fought and they're about to die. Okay, so that is called TEMRA cells. Okay, my point is you just remember the naive cells because these are the very important cells. When a patient is having low naive cells, then it is a feature of immunodeficiency, combined immunodeficiency. Because naive cells are the one which is the cells which are the reserve. When the patient is having very low naive cells, then it is an evidence of immunodeficiency. Okay, for example, when you have a good CD3 count, say for example 1200 or something, and when you do a name and memory analysis like this, you find that only some 50 cells are there in the name and its remaining cells are distributed between the central memory, effector memory and the differentiated cells. Then that is an evidence of leaky skin. Okay, it's evidence of combined immunodeficiency. That is the reason why I'm telling you name series. Okay, so extended T cell subset analysis is useful for diagnosis of atypical SCID cases. So I told you in severe SCID, the lymphocyte count will be around 300. There may be atypical SCID or leaky SCID where the count may appear fairly normal. By count wise, you find like, okay, this appears normal. Even your basic lymphocyte subset analysis will find good population of T cells. But when you check the name and memory, you find all those cells are of memory type and not name type. And that is an evidence to find that this patient is having a leaky SCID or atypical SCID. Getting it? So T cells present in normal or slightly reduced number in contrast to classical SCID where it is markedly reduced. Okay, if you have any doubts, stop me, okay? So similarly, we have another marker like RO, which is a memory marker. Instead of using this combination of RA and 27, I can also use RA versus RO. RA is A for naive. Just remember like NA, right? So RA is naive. RO, memory, O, right? So memory, okay? So you can also check the differentiation between naive and memory. When you find no cells here and the complete cells lying here, then it is abnormal. Okay, similarly here. Okay, so that is what naive cells and memory cells all mean. And as I said, you need to have the normal reference ranges when you are reporting these results. Whatever counts you are getting, you need to check with the age-matched reference range for that particular subset and then say whether it is increased, decreased or normal. Okay, so you can't report lymphocyte subset analysis without reference ranges. Okay, now this is another case where the gated T lymphocytes, okay, as I said you now, predominantly in the naive state because it is RA positive. This is normal. But you see here, this is a patient of leaky skin. You find the predominant T cells are RA negative and only a small subset is RA positive. This is a leaky skin. So if you just check with basic lymphocyte subset analysis, this may appear like it's all fine. But once you do this, you find that these cells are qualitatively abnormal because predominant are in memory state and naive cells are very low, which is indicative of leaky SCID or atypical SCID. Okay. Okay, again, this is a case of same atypical SCID. You find here normal T cells and there is a labeling error. This is cytotoxic T cells and this is helper cells. You find the RA cells are very low in number. Predominant of them are RA negative, which is all memory cells. So this is abnormal leaky SCID. Okay, so if the T lymphocyte count is also normal, still the child could have SCID. Okay, one is what I told you, leaky SCID or atypical SCID. The other is something like Bowman syndrome where the existing T lymphocytes are all in activated state. If you see T lymphocytes with HLA-DR, only a small subset of T cells will show HLA-DR. Those are those cells which are activated. It should be around say like some less than 10% or 20%. But when you find the entire T lymphocytes in the activated state, okay, as we saw in memory state for atypical SCID, then that is the diagnosis for Bowman syndrome. Okay, so these terms, everything what I'm saying may be very difficult for you, but still I just want to expose you to this particular things so that in future you can read and start doing about this. Okay, so this is Bowman syndrome where the T cells are all activated state. HLA-DR is an activation marker for T cells and you find all the T cells are in activated state. Okay, and then this I told you, right, B cell class switching. So you get the B cells and check across IgD versus CD27. Okay, I have duplexed here, but still you check IgD and 27. So the naive cells are IgD positive and 27 negative. But as they go into the germinal center and go for class switching, you find these cells will lose IgD, okay, as they are switching for other immunoglobulins, and it slowly becomes 27 positive. So this is a pattern with class switching. And whenever there is class switching happening, you find plasma cells, which I can find it with bright CD38. Plasma cells are bright CD38 positive. But you see this is double negative T cells. In cases of CVID or hyper IgM syndrome, what happens? This differentiation is arrested. So you find one big cluster sitting here. This differentiation will not happen. So that is a class switching arrest or defect in class switching. Okay, and you also find no plasma cells. And this is double negative T cells, which I told you. Okay, so alpha beta positive T cells. In fact, you created a panel for this, right? So alpha beta positive T cells, which are negative for both 4 and 8, should be normally around less than 2.5% of CD3 positive cells. When it is more than that, then the diagnosis of autoimmune lymphoproliferative syndrome is given. Okay, so these all can be diagnosed by extended T cell analysis. Okay, similarly, T regulatory cells, I told you what is T regulatory, right? To act to suppress the immune response, thereby maintaining homeostasis and self-tolerance. When these cells go down, then there may be high chance of autoimmunity. And similarly, in the bone marrow transplant setting, this is the reason for graft versus host disease. Okay, so Treg cells are CD4 positive cells, which high expression of CD25 and FOXP3. And I also said what is RTE. So these are cells which are recently emigrated from the thymus. So in patients with T cell defect, like severe combined immunodeficiency, you don't find good number of RTE, recent thymic emigrants. Okay. Okay, maybe confusing, but don't worry. This is how it is. I just want to give you a glimpse of it because in future it may be helpful if you're interested. Okay, so now lymphocyte subset analysis by flow cytometry will go into the practical thing. So you all know this. This is very similar to CD34. A known volume of sample, for example, 100 microliter of sample is added to the fluorochrome labeled antibodies. So what are the markers needed? Now I'm telling you only the basic subset analysis, basic lymphocyte subset analysis. So the markers needed are CD3, CD4, CD8, CD19 or CD20 and NK cell marker, which is 16 and 56. So these are the markers which are needed. Okay. So you had a known volume of samples, say for example 100 microliter to fluorochrome labeled antibodies, which is 45, 3, 4, 8, 19 and 56. The fluorochrome labeled antibodies in the reagent bind specifically to the cell surface antigens. Okay, now these antibodies will go and bind to the respective antigens. Then you are lysing the sample. So after staining, you are lysing the sample with ammonium chloride based lysine solution. Once you lyse it, you add a known concentration of beads. Now this known concentration of beads should be same as that of the sample volume. If you use 100 microliter of sample, then you add 100 microliter of beads. Now the manufacturer would give you the beads where how many beads are there in 1 microliter. That value you know that. You will be given with the kit insert. So that is why this is called calibration beads. Since you already know how many beads are there in 1 microliter and you are adding a known concentration of these beads, volume of beads, similar to the sample, with this you can identify the absolute count of cells. Okay, and then you do the hierarchical sequential gating to isolate the populations and enumerate them. Okay, so this one I'll show you. And you know what is absolute counts by two methods, single platform and dual platform. Single platform is something like you do completely in the flow cytometer. You get the absolute counts, percentages, everything from the flow cytometer. Dual platform method is where you get only the percentages from flow cytometry and calculate the absolute count from the total WBC count from the automated cell counter. Okay. For CD34, it is mandatorily you need to do it by single platform method. But for lymphocyte subset analysis, you can decide whether you want to do a single platform method or a dual platform method. If you want to be very cost efficient and don't want to save money, then you can do dual platform. If you feel quality is more important and I don't want to do it in two platforms, then single platform is fine. Okay. So any doubts? Can we just see some cases? Can we see some cases? Do you have any doubts now? If you have any doubts, we can ask me. I'll stop this screen sharing and I'll come back. Okay. So is my screen visible? Yeah. Any doubts? No doubts? So is that so crystal clear? Okay, now we'll go ahead. Now, see, this is what I told you. Like when you have a file like this is because a preset template was set in the machine and you already have a preset gates formed here. So when you don't have an efficient flow cytometrist to interpret the data and still you want to do CD4 counts, now what the company person, application person does is he draws the gates with control samples, okay, something like this. He fixes the gate, and finally what happens is that whatever population which comes, the values will come like a tabular column saying CD3 is so much, CD4 is so much, CD8 is so much, 19 is so and so, 56 is so and so. So, and you just enter the values and give the report. See, but the problem here is like you need to check whether the gates are all rightly placed. Only when the gates are all correctly placed, then the values are correct. For example, someone who's inexperienced is shifting the gate like this. Now your values may go wrong. If you have not checked this and you are just giving it by the numbers which the tabular column is showing, you are wrong. This is one point. Second, if, for example, if the company person, to avoid these problems, if he's fixing the gate and locking it so that nobody can move it or adjust it, if there is any problem in the voltage of the flow cytometer, now this particular population, for example, instead of lying in this negative region, because of voltage alteration, if it is shifting to this area and this is shifting to this area, now these two populations will all be calculated as T cells and it will be giving a false number. So that is again another problem with checking this, doing lymphocyte subset by this already gated protocol, which we call, some people call this as lock protocol. You can do that, but still you need to have an idea and check whether the gates are all correctly placed. For example, if the gate is something like this, then you need to adjust to correct position so that you get the correct values. Okay. Now what I'm going to do is, I'm not going to do any of this. We'll gate independently from the beginning. Okay. So let's create some plots and you know how to approach. The first plot you need to check with time and forward scatter for stable acquisition. So that's fairly okay. Then you need to check viability. Okay. So you should eliminate events which are having low forward scatter and side scatter. So once I eliminate, I'll get only the populations which are viable. Then what I need to do, what is the third plot?
Singlet.
Singlet plot. So forward scatter P versus forward scatter area. Okay. So I repeat, peak is otherwise called height, integral is otherwise called area. So I'm just getting the singlets, excluding the doublets. After that, side scatter CD45. Right? So I'll get only singlet, that is C. Okay, clear? Any doubts till now? No doubts, right? So now I find the neutrophil population, a monocyte population, a lymphocyte population, and a small basophil population. Now I'll get the lymphocytes. Okay, so now I'm getting the lymphocytes because my population of interest for further analysis is only this, not monocytes or neutrophils. So now I need to check with CD3 versus CD19. Okay. Now I'm going to put only the lymphocyte population. Right? And I'll put the quadrant like this. Now everyone agrees these are B lymphocytes. I'll give a color to it. So B lymphocytes are sandal color. T lymphocytes are sky blue or equator blue color. And you have a double negative population. Okay, now second plot is to find the NK cell. So I'll put the NK cell marker along with CD3. Okay. Now what I need to put? I need to put the double negative population, so I'll just gate that. Okay. So what is the name of this gate? It is H. So I'll drop H in this. So now you find, so I'll give a darker color so that you can all see. So I'll give, what color can I give? I'll give dark green. So now you see that this population splits into two. The one which is expressing CD56 is NK cells. So NK cells are also done. I'll just give some color to the NK cells. Okay. I'll give red color. Okay, so these are T cells, these are B cells, and these are NK cells. Now let me check the percentages. Okay, so if you check, the B cells are around, out of the total lymphocyte population, it's around 62%, and so I'll just name the gate so that there is no confusion. So these are T cells, and these are B cells. Okay, now T cells, B cells are around 17.06% and T cells are 62.53%. Now NK cells, I cannot take this because I have just taken this population. So I need to put again the entire lymphocyte population, which is D. Okay, now check the percentage. So I label this as NK cells. See, if any doubts, please stop me there. NK cells. Now check the percentage. Percentage of gated. So NK cells are 12%. So 62% is T cells, 17% are B cells, and 12% are NK cells. Now, if you are using a dual platform method, okay, now you would note down these percentages. Check how much is the absolute lymphocyte count in the cell counter, and from that absolute lymphocyte count, you can calculate these three population absolute counts. So absolute T cell count, absolute B cell count, absolute NK cell count can be calculated from the absolute lymphocyte count, which is given from the counter. If you are using a single platform method where if you have added the beats, now you need to gate the beats. Okay, so I'll draw one more plot. Now my thing is I need to find where are the beats. So beats are structured in such a way that they have the highest scatter, high side scatter and high forward scatter. So it may be somewhere here. Okay, now let's check with the fluorescent parameter. So these are the beats. Can you find this one? These are the beats. So what I do, I'll just gate them. Okay. Okay. So I can still refine them with the time plots, whether this one we have already done with CD34, something very similar to that. Once you do, you just gate this and label them as beats. Okay. Now, if you are using a software, you can directly enter the details here and you get the automated values. If it's not software and if your software doesn't have that facility, you need to check the number and you need to check the number of each of these populations. And by knowing the concentration, I have just shared the formula for that during the lecture of CD34. Okay, but since I have the software here, what I'll do, I'll just put it to the software for calculating. So beat gate is what I've labeled as beats. So I'll select beats. Calibration factor is in 1 microliter, there are 1000 beats. So I'll add 1000 here. Okay, I'll enter and then I'll close this. Now I have given the calibration detail values. Now I can directly get the absolute counts. Check. Now what I need is cells per microliter. Okay, what I need is cells per microliter. Now you find your B cell count is 977 cells per microliter T cells count is 3,581 cells per microliter, and NK cell count is 707 cells per microliter, which is fairly normal. Okay, given without, so I should not say that without age matched reference, but still I know this case, so it is normal. So that's how you need to do. So once this tube is done, now you go for the second tube, because this is a company given cocktail. So this cocktail means the antibodies are already mixed together. So you have to do by two tubes. If you are doing by my way of manual gating, then you can include all the antibodies. In fact, 4 and 8 in this tube itself. But this is what I said, by acquiring by protocol, because we may not have time for us to just check my. So the technician does these counts. Of course, he's well trained to check all these gates. So this is basically, you have two tubes, 4 color 2 tube. Okay. If you have a 8 color instrument and you prefer manual gating, you can add 4 and 8 into this, and you can still finish off the job in single tube. But since it's a company cocktail and it's a structured 4 color one, we run 4 tubes. Now similarly, you have multiple tube plots here, which I'm not interested. These are all auto locked protocols, so I'm not interested. So what I do, I'll draw my own gates. So the same gates, but due to time, I'm not drawing the time plot and the singlet plots, which is wrong, but due to, okay, so I'm directly going. So some doublets may be mixed here, but initially you need to start with the time plot, live, then a viable gate, then singlet gate, and then only you have to come here. But because of time, I'm directly going with site cut CD45. You can also directly start, you can without site scatter CD45, since in this particular tube you want to check only CD4, CD8, you can directly gate across site scatter versus CD3. Okay. So there is compensation. Okay. Now gate it. Now you put this. You can put, or you can directly gate like this. So you gated the T cells. Okay. Now you need to check how much of T cells are 4 positive and how much of them are 8 positive. So gate 4 here and gate 8 here and plot 8 here, and then apply the gate here. Sorry, the lymphocyte gate. Okay, so now you have the percentages again. So you check the percentages. So 63.2% are T helper cell. 31% of the T cells are cytotoxic T cells. Okay. Now to get the absolute count, same method. What you do, you need to get the beats. Okay, with forward scatter. With any of the fluorochrome, if you check, you can find the beats. So you find the beats here. Get them. Okay. Now you need to refine them with the time plot. Better to do that. Okay. Put the D. Then you get them. Okay. Now label this as beats. When protocol options, select the beats, and calibration is 1000 beats on microliter, so that is done. Now you can get the absolute counts directly. So CD minus plus is CD4 positive T cells. So I'll just label them. Okay, now you can check it. CD4 absolute count is 2344 cells per microliter, and CD8 absolute count is 1153 cells per microliter. Clear? Any doubts? So that's how you do a simple basic lymphocyte subset analysis. Any doubts? Nobody has a doubt? Very easy, right? So during assessment, I'll check. How many of you mean, like, you please download Kaluza, just give you a hands-on experience. Those who have Kaluza or other software, it's fine. Those who have not yet checked the software, please download the trial version. I'll give you some files to play with. Some, like, you just work on it. You have a feel of it. You'll enjoy it really. There may be a bit of toughness, like maybe some difficulty to download it. Once you have downloaded it, the trial version exists for 1 month. Okay, so in that 1 month, you just play with some cases. Nothing you're going to lose, right? So you just try, check it. If you have any doubts, please ask us or ask me, and I can help you out, because this is a chance to learn. And if you're missing this, then I don't think so. Like when you get the chance, it may be difficult. So try to put your hands on and work on the software so that you will understand and learn it. Okay. If you have any doubts regarding that, you let me know. Okay. Now this is about the lymphocyte subset analysis, and now these are some of the cases where you can find some immunodeficiency. Okay. Now you see this case. C3 is very low. Okay, this one I've already gated. So time plot, then viable gate, singlet gate, and you find this case, I've gated the lymphocytes, these are the monocytes, and when I plotted the lymphocyte across 19 and 3, you find 19 is fairly normal, but the CD3 count is less. You want to know how it is the absolute count, so let me get the beats. Okay, I'll just check it here. Let's check with it. Percentage created. Right? You find normally the T cells will be more than the B cells, but here you find the G is the B cells, which is 80%, and it is 1021 cells, which is normal or slightly higher than the normal range. But you find the T cells just 127 cells. So this is a case of combined immunodeficiency. Okay, combined immunodeficiency. Though B cells are there, the T cells are very low, so it's a combined deficiency. And how about the NK cells? NK cells are present. Okay, the NK cells are present. So NK cells are around 70 cells, which is fairly okay. So NK cells are there. So this is a case of T negative, B positive, NK negative combined immunodeficiency. Okay, so this is one case. And this is another case, the same case. If 3 is low, obviously 4 and 8 will also be low. So there is low, very low 4, and again very less number of 8 cells. So this is the second tube of that particular case. Okay, now I'll show you one extended phenotype. Okay, which I've already done. So this is what I report. Okay. Now this is extended phenotyping, so similar viable gate. Then you see the markers here. In contrast to that, now I am using these many markers for extended T cell, extended lymphocyte subset analysis. 3 for T cells, 1656 for NK cells, 45RA to subtype the naive cells, naive T cells, IgD for checking out the naive B cells, CD38 to check for plasma cells, CD4 for, of course, T helper cells, IgM again for naive cells, 19 for gating the B cells, 27 to check again the naive cells, memory, central memory, effector memory, HLA-DR to check for its expression in B cells in cases of MHC class 2 deficiency, and to check the T cell activation status. As I said, only a subset of normal T cells will be showing HLA-DR. The rest of them will be in a non-activated state, which are HLA-DR negative. But in cases like Omen syndrome, almost all the T cells will be in an activated state, which will be HLA-DR positive. So in that way, you can diagnose Omen syndrome. So this is the markers, and this is how we gate. So we gate the lymphocytes. First viable gate, then gate only the CD45 positive events, then gate the lymphocyte. Then I put the lymphocyte gate, in 19 and 3 as I showed you. So the 3 positive cells are T cells and 19 positive cells are B cells. Then the double negative I put in 56 and 16 and get the NK cells. Okay. So NK cells, the B, T and NK is done. Now again, as we saw there, in single tube, now the T cells is gated across 4 and 8 to check how much is helper cells and how many are cytotoxic T cells. Once this is done, now so the basic lymphocyte subset analysis stops here. Now in extended, now I'm going to still explore these populations, CD4 and CD8. So how do I do? CD4, I gate it across 27 and RA and check for naive, central memory, effector memory and tempora. Similarly, CD8, I gate across CD27 and 45 RA and I'm checking for naive, central memory and effector memory and tempora. For example, here you find the naive CD4 percentage is higher compared to other populations. So this is fairly okay distribution. If the naive is lower than the other populations, say for example, if it is 10%, then this is abnormal. Okay, and that is how leaky skid or atypical skid cases present. Okay.
So what will be the normal percentage of all these 4 cells? Like central memory, knives?
I can share it on the WhatsApp group. I've shown you a tabular column, right?
Okay, sir.
You can just check that. I'm not a superhuman to memorize all those things. Okay, so I can just share it. You can. What I do is during my reporting, I just stuck it to the wall opposite to my analysis, so that I can just check from that and I'll report. And this is another case. So HLA-DR, I told you, normal T cells should show only a small tail of HLA-DR positivity. If you want to check the percentage, you check like only 1% of activated 4 is there, and similarly, normally CD8 shows more activation, so it's 13%. When this becomes ulta, so where you get this cluster here and a very small population is HLA-DR negative, and similarly the reversal way you get, that is how you diagnose Omen syndrome. Okay, so that is one way of diagnosing Omen syndrome. And then again, this is for HLH, okay, because cytotoxic T cells with co-expression of 38 and HLA-DR greater than 7% is indicative of HLH in cases of biomarkers present. That is high ferritin, high triglyceride, low fibrinogen. When that is present and when you have CD8 positive T cells co-expressing 38 and HLA-DR greater than 7%, then it is suggestive of HLA. It is suggestive of HLH. Then here, coming to the B cells, I'm checking for class switching. You see the beautiful class switching pattern happening. So these are naive B cells. Once they encounter the antigen, they slowly differentiate to activated cell or class switching. So they lose IgD and they acquire other immunoglobulins, and slowly they start giving expression of 27. So these are class switched memory cells and these are naive cells. And then you can also check the plasma cells by bright CD38 expression. So when this is a normal case where you can see all the normal patterns. Okay, so finally the double negative T cells you can separate into gamma delta and alpha beta, and you can give a beautiful report like this, something like this. Okay, you can give a report of all the subsets. Now if you're using a basic lymphocyte subset, you will give only this, but when you do an extended subset, you can also give this. Okay, and of course what I said you there. And along with the report, you need to give the reference ranges, what we just asked for, right? So these will complete it. Okay. Any doubts? Yeah, I could just easily completed the basic lymphocyte subset analysis and I would have easily finished the class, but I want to show you this is an extended lymphocyte subset analysis is always better to do than a basic lymphocyte subset analysis. I just want to show you a glimpse of it. So in your future, if you're doing, definitely try that. Any doubts?
Sir, what is the role of CD25 in subset analysis?
CD25, correct?
Yes, sir.
See, CD25, as I said you, for T regulatory, it is useful. CD4 positive T cells, when it is 25 positive and FOXP3 positive, it is T regulatory cell. One. Second, CD25 is also an activation marker like HLA-DR in T cells. Okay?
Okay.
So they also check for CD25. That is again one more advantage. Yes. Any other doubts? No doubts? So if you have any doubts, please put it in the WhatsApp group so that I'll take it up. And so I'll be giving some cases which you need to analyze and tell me. So that is assessment 3. So we have done assessment 1 and 2, and this is assessment 3, which the cases I'll post it tomorrow basically in the group. So you can download the trial version of Kaluza. I'll again post that trial version, how to download that. So you can download, work on those files and try to give some result. So that will be your assessment 3. And next week, Friday, we'll have the final session of this course, which is, as I said, you will be having on reporting guidelines and how to give a flow cytometry report, what all should be mentioned, and what are the quality measures you need to take, quality control in flow cytometry lab. So with that, we've closed the basic flow cytometry.